All right, so guys, I am Stefan Samuelson from the Department of Anesthesiology. The research that I'm going to present is on the use of simulation to create a resident warm-up for procedural skills in anesthesia. So endotracheal intubation, I'm not sure if everyone is familiar with it or not. Basically, it's the passage of a tube through the oropharynx or nasopharynx into the trachea. Tube sits just above the carina. It's used to ventilate the lungs. It's a life-saving procedure for patients that have compromised respiratory function. It's also a component of general endotracheal anesthesia. Most anesthesia residents will perform this procedure hundreds of times within their residency. By the end of your first clinical anesthesia year, you've done it at least 100 times. So it's something that we do frequently. The basis for endotracheal intubation, usually we do it under direct laryngoscopy. We have a blade, we see down to the larynx, we pass the tube. It's all done under direct visualization. However, there are a lot of patients in which that's not possible, or it's very difficult. It can be everybody who, from those who have tumors in the airway, congenital malformations, injuries, and more frequently we see, as you see on the bottom right, patients that are obese, patients that have other reasons to have airway collapse, people that it's not safe for us to do it in our standard fashion. So for these patients, we offer a number of interventions culminating in fiber optic intubation. So fiber optic intubation is basically the passage of a flexible bronchoscope through the airway down into the trachea. The tube sits on the bronchoscope and is slid over the bronchoscope into the trachea. And as you can see, it's done, usually there's people helping you. The old scope, you used to look directly into the scope. Most of the new scopes have, as you can see, the screen on the left there. It's a display, basically, that you're looking, and whatever the scope is seeing is displayed on the screen. So it is the standard of care for tracheal intubation in patients that have a difficult airway. Again, there are other interventions, but this is where it culminates. It's an essential skill for all anesthesiology residents to have completed by the time the residency is completed. It is an advanced technical skill. It has a very steep learning curve. It's not necessarily intuitive for many people. So traditional preparation for this, like for a lot of procedural skills, you read about it, you're lectured about it, you hear about it, you think about it, and then you practice on live patients. It can be a very stressful situation in the operating room trying to learn this procedure. You have an attending watching you, there are other people in the OR, there's the patient who you're hoping is not going to desaturate before you get the tube in place. It's a very stressful situation. This might not be adequate for people to finish their anesthesia residency and feel like they're competent in this procedure. So recently in the surgical literature, there's been the idea of a warm-up. Basically, this is the idea that you have some sort of an exercise that will prime and refresh your skills before you have to actually use them on a live patient. Similar to a warm-up if you're going to run a race, do a dance, anything like that. And what we wanted to know is if you could do this with procedural skills in anesthesia, because it hadn't been tried yet. So we designed an intervention. Our intervention would be a 5-minute hands-on virtual warm-up immediately prior to performing fiber optic intubation. It would be done on a high-fidelity bronchoscopy simulator, which I'm going to show you in a second. The hypothesized outcome would be whether or not this could improve resident performance of fiber optic intubation. And because speed does not necessarily equal safety, what we wanted to do was measure the time it took to perform the intubation as well as grade the actual skill using a validated skills scale by which attendings could actually judge how well the resident performed the procedure. So this is the bronchoscopy simulator we used. It's an immersion medical simulator there on the left. You can see that it has an airway there. In this case, it's a nose. It could have been a mouth. There's the screen that you'll be looking at. And this here is the bronchoscope. It looks and feels exactly like a real bronchoscope. It doesn't quite function the same way, but for all intents and purposes, it's a bronchoscope. There you see Dr. Adam Levine, who's performing a bronchoscopy with the simulator. And down there's the view that you see. That's the left and right mainstem bronchi and the carina. That's the thing that we're trying to see before we pass the endotracheal tube. So we recruited CA1 and 2 anesthesiology residents. That correlates to PGY 2 and 3. This is your first and second full year of clinical anesthesia. We decided that they would all perform elective asleep oral fiber optic intubations. This would mean that they were patients that it wasn't as dangerous if things took a little while. They would be standardized. People wouldn't have to navigate the nasopharynx, etc. And we chose patients that were ASA class 2 or below, meaning they're relatively healthy patients that have Malampati class 1 and 2 airways, meaning that the airways would not be particularly challenging airways. We did all this to keep things as standardized as possible. We divided the residents into two cohorts. The first cohort was the warm-up cohort. They performed a 5-minute continuous hands-on virtual bronchoscopy exercise, basically, with a research assistant helping them. And then they proceeded immediately to live fiber optic intubation in the operating room. The control cohort, basically these residents were pulled from the operating room for 5 minutes. They had a rest period. Then they went back in and they also performed fiber optic intubation under attending supervision. The attendings were blinded to the cohort that the resident was in. These are the warm-up cases that the residents went through. I just want to point out they were basically designed so that the first case was the easiest, the last case was the most difficult. They would just proceed through as many cases as they could get through within 5 minutes. The last case, it's a female infant. Again, they weren't intubating a female infant, but on the simulator, this is about the most challenging airway that you get. So for time, we standardized that to be in the live intubation, the time starting when the bronchoscope passed the tip of the incisors to when they visualize the carina on screen adequate to put down the scope and begin sliding off the tube. For graded technical performance, we used this scale. It comes from Toronto. It's been validated in many studies. Basically, it has 9 categories. Each one you can score a maximum of 5 points. You get a total at the end, and that's your skills scale score. And it's everything from how often they banged the tissue to how well they kept the view to if they knew the names of the instruments, etc. So it was definitely applicable. And what we did to standardize this as well, avoid bias, we had the attending that was in the room rate them, and then we had a second attending who would review video recordings of all the residents doing the procedures and would then scale the procedures as well. And then the average of those two scores would be taken. In most cases, it was pretty similar, the two ratings. So to control for prior experience, because we knew that residents come from different backgrounds, we mined ACGME case logs as well as computerized operating room records. Every person who gets a breathing tube in the operating room, the method of the breathing tube is recorded. We also, so basically we recorded the total number of fiber optic intubations that each resident had performed. We also recorded the time in days since the most recent fiber optic intubation. For intrinsic factors, so we were concerned that there could be bias. For example, everybody who has very good hand-eye coordination just randomly winds up in one cohort. It's going to skew our results. So we decided to do a crossover design. Basically what we did, so we started with all of our participants. They were divided into each cohort, and then they went through the procedure. After a minimum 2-week interval, we crossed everybody over to the other cohort. So if you were part of the warm-up cohort, you then crossed over to the non-warm-up cohort, and vice versa. You then were sampled as if you were a brand new subject, including number of previous intubations, time since previous intubation, etc., treated as a new data point. We did this so that everybody had a chance to participate in each cohort with this washout period. So we wanted to do a multivariable analysis. We would be controlling for previous experience, time since last intubation, and then whether or not they had this warm-up. And then the dependent variables, we had 2. So one would be the time it took them to do the warm-up, and the other one would be the skills score that they got from doing the procedure. Excuse me, I said time to warm-up. I meant time to intubation. So we got a total of 33 anesthesiology residents. 2/3 were CA2s and 1/3 were 2/3 were CA1s and 1/3 were CA2s. All participants completed participation in both cohorts, and all residents were able to successfully perform fiber optic intubation twice. So I just wanted to show this slide to you so you can see we had a wide range of all of our independent data points. The prior number of fiber optic intubations was everywhere from 2 to 43. Time since most recent intubation was everywhere from 1 to 147 days, and this was scattered throughout both cohorts, so there was a lot of variety. The raw results, so you can see that I'll show this graphically in a moment, but I just want to point out that in every case we had, and we divided it up into CA1s and CA2s because we also wanted to see if there was a difference in people that had just more overall experience. And what we found out is that for all residents, for CA1s and for CA2s, there was a very significant difference whether or not they had the warm-up in both their time to completion and in their skill score that they got. So I'll show this graphically. This is the time, and the blue represents the time without the warm-up, and the red represents the time with the warm-up. There was a significant time savings for all of this, and I mean it was pretty striking. In many cases, it was very striking. After the warm-up, they would just go in, and it was they already knew the way. They would go straight on through. And these are the scores. So the scaled scores you can see. So for all participants, the mean scaled score was 39.6 without the warm-up, 39.6 with the warm-up, 34.1 without. And this persisted through CA2s and CA1s. Again, with the scale score, a higher number is better, as opposed to the time where a lower number is better. So you can see there was an improvement across all categories for this as well. Now, there was one thing that came up a lot when we were doing the study. That was the idea that if we were going to do a crossover, how do we prevent bias from the crossover, right? So if you'd already done a warm-up for the first branch of the study, and then you came back 2 days later and you did it without the warm-up, would you still be getting the benefit of the warm-up, or vice versa? You know, would there be, say you had a 50-day interval between your two intubations as opposed to a 2-week interval? So this went far over my head statistically, so we recruited our statisticians across the street, and they calculated period and sequence. So period is basically refers to the time interval between the two branches of participation. Sequence refers to if they did the intervention before the non-intervention or vice versa. And there was no significance anywhere for all of these, for all residents, for CA1s or for CA2s. You can see it doesn't even approach. So basically that validated our crossover design. It was a way for us to be sure that we didn't create bias by doing that. So in terms of this study's applicability, so the first thing that we are pretty sure about is that the warm-up significantly improved the resident performance of fiber optic intubation. That was both in terms of speed and in terms of technical performance. The benefit persisted when controlling for experience and intrinsic factors. So again, that was with prior number of intubations, time since previous intubation, and overall experience level. And it stayed consistent. In terms of applicability to patient safety, so there are patients in which seconds make a difference. It might not seem like a huge difference if you're talking about it taking 30 minutes to pass a breathing tube as opposed to 30 seconds to pass the tube as opposed to 45 seconds or a minute. There are patients in which that makes a big difference, or patients in which you can't create trauma as you're trying to do the intubation. You've only got a limited chance to perform the intubation. This is something that we worry about a lot in anesthesia. Everyone has their procedures that are their own. This is one that we definitely are concerned about, because frequently when we are resorting to fiber optic intubation, it's an emergency situation and we need to do it right the first time. So the other idea that we came across is, although this was performed in a resident setting, this could be applicable to practitioners that are in the field that haven't done this for a long period of time. If we could come up with some sort of an intervention, some sort of a warm-up that was portable, something that people could do, and there are studies that have been released even prior to our doing this on using setups such as syringes taped to a table, etc. Find the proper hole in the syringe, etc., to do the warm-up, just to get your hands familiar with the procedure. Because the idea is that you're waking up your muscle memory and you're reviving your mental picture of how the procedure goes. So it doesn't necessarily need to be a large high-tech simulator in order to get the benefit. We would like to investigate the idea of warm-up in other technical skills. This just happened to be the one we chose because it's the most technical skill we could come up with that residents would be performing. And there's also a study that has just been recently released about using an adaptable virtual simulator to basically create a virtual airway that mimics the airway that you're about to intubate. So for example, someone has a massive intratracheal tumor that you're going to need to intubate around. It would be a way to actually practice that particular airway. And there's been one study, like I said, that's been released on that. Hopefully that technology will continue to improve. And ultimately we'd like to create the bridge between simulation and patient safety. It's kind of sat on the side for a while in terms of playing with dolls, playing with computer programs, etc. Sort of a teaching tool. We'd actually like to incorporate it into patient care. I think it actually has a lot of potential in augmenting patient safety as well as practitioner skill. So, questions?
Has anybody done this using the warm-up an hour before, 2 hours before? You chose 5 minutes.
Right. So the reason we chose 5 minutes, there has been, most of the studies that have the warm-up, They don't even call it a warm-up. Most of the studies that have the simulation intervention at some time period that's more extended before the procedure itself are using it as education, not as a warm-up. There have been plenty of studies that have been released on using a bronchoscopy simulator to get people better at intubation, but those are basically just for didactic, for education. It's taking. For example, there was a study that took a cohort of pediatric residents and had them use a bronchoscopy simulator as opposed to not use a bronchoscopy simulator, and then attempt intubation of children. And it's no surprise they found an improvement with the simulation because residents got to actually practice the procedure. However, this is the first time that anyone has tried to use simulation as a warm-up like this. It's a fairly recent fairly recent concept in surgery. Usually it looks at laparoscopy in surgery. They'll take residents and put them through a series of exercises, either on a virtual laparoscopy simulator, or one study basically created a bunch of part tasks. You had to pick up a ring and put it on a pole. You had to tie a knot, etc., and would have residents do this and then go perform laparoscopy. So again, the ones that are focused on warm-up have all come from surgery.
Will the learning skill last till the next day?
So there has been studies released on decay skills. I believe it does persist to the next day. We chose the 2-week washout period. I don't want to say it was arbitrary, but there was no study that said you'll lose procedural skill after 2 weeks. Most of the studies that looked at loss of procedural skill looked at years out, people that hadn't done them for quite a while. Would look at people that have been in anesthesia practice for 15 years and compare them with procedural skills to people that have been in anesthesia practice for 2 years. And they would find skill decay in things that you hadn't done in a while. In terms of persisting the next day, I mean, it makes sense to me that it would, at least the psychological component of it. Your hands might not be warmed up, but mentally you'd be more familiar with the steps that you need to complete. And in fact, the skills scale that we had actually did have components both of the physical skill as well as the psychological preparation.
And do you think that the impact of video-assisted laryngoscopy is going to be such that people are going to be doing fiber optic intubations less and less?
So that's a hot question in anesthesia, as I know you're aware. There are a lot of airway devices that are released. If you go to the emergency room, I would say the majority of their intubations in the emergency room, they have the glide scope in use if not available. A lot of these devices serve a couple of purposes. You can get an electronic image of the airway, and the people that are with you also get an electronic image of the airway. However, anyone who's done a lot of these procedures with those devices knows that it's one thing to get a picture and it's another thing to pass a tube. Just because you can see it doesn't mean that you can actually manipulate it. And in fact, you can create a lot of damage with these larger instruments that you put in the airway, large cameras, blunt edges. There's a lot of trauma that goes on with these devices. I don't believe that they should or will replace bronchoscopy. Bronchoscopy has a particular elegance in terms of being able to snake around tortuous airways, get around difficult friable lesions where you can't stick a large other device in order to create it. It basically is the last step between being able to intubate through the nose or the mouth and having to do a tracheostomy. If you can't do it with a fiber optic bronchoscope, chances are you won't be able to do it. So yeah, that is a big question in anesthesia. If people are relying on these other devices and losing skill with skills that require more finesse, like bronchoscopy.
I think it would seem to be perhaps the way the national organisation is moving. The ASA is tending to say more, particularly in the difficult airway algorithm, that video-assisted laryngoscopy may, in many instances, I mean, I'm just being a bit argumentative here, I know, may in many ways replace fiber optic intubation.
Well, again, the purpose of the ASA is to ensure patient safety as much as possible. And again, if you have a procedure that some people are better at than others, or that people don't do frequently, it's tempting to say, fine, let's just throw it out. Let's not rely on that procedure at all. Let's do something that everybody can do. You can put a glide scope in there and you can get a picture, and then hopefully you'll be able to pass the tube. I mean, if you look at our institution, obviously, our institution, we are pretty adamant about teaching fiber optic intubation, and I think our residents graduate very good at fiber optic intubation. And someone that has a good baseline skill in this procedure, like any technical procedure, if you get comfortable with a procedure by the time you leave your training, it's something that you're more likely to fall back on when you need to. I personally, if there's any question at all that I need to perform a fiber optic intubation, I perform a fiber optic intubation. I don't see the downside to it as long as my skills are fresh. This is basically a way to make sure that my skills are fresh. Yes.
You talked about the challenges sort of translating this out to the practicing population. Mm-hmm. Has there been any thought about translating it down to the undergraduate population? Maybe not the specific procedure, but the concept of the warm-up and how helpful that can be.
Sure. I mean, there's no barrier to that. There really is no barrier to that. And in fact, the younger the generation, the more familiar they are with technology. That seems to be the trend. I know my 5-year-old nephew is better with an iPhone than I'll ever be. The younger generations tend to be more familiar with technology than the generations that are preceding them. I think that it would be very easy to offer this to undergraduates, people that are earlier in their training. They might not have any interest in trying to find the carina as an anesthesia resident will, but in terms of using the bronchoscope to find a particular path, for example, anything like that. I mean, there's no reason not to. All we're really doing is finding a way to. I mean, if you look at the one picture of the intubation, it's a really bizarre way to perform a medical procedure on somebody. Your patient is in front of you. You're not looking at the patient. You're looking to the side. You've got things in your hand. You're not watching where your hands are going. In all the time in medicine, there's like when you're placing a line under ultrasound, there's a question of, well, where do I put the screen? Do I put it over here? Do I put it here? And if you put it here and you're going down here, there's always a chance you're going to stick a big needle in a vessel it doesn't belong, right? So it's not an intuitive procedure to be able to do this. So the whole idea of the warm-up is basically to take this non-intuitive procedure and get your body used to it for a moment so that it doesn't feel unfamiliar, so that you don't think, I need to move right, and you go down or something like that. It's a way to just get your mind and your hands working together. So there's really no barrier to using this concept to people at any level of training. Yes.
I guess like in the exercise world, we say warm-ups are good for everybody, right? And maybe even as you get more advanced, you have to have more warm-up, not less warm-up. But it's like you're not necessarily suggesting that all anesthesiologists do a warm-up before they do the procedure.
I'm not suggesting that all anesthesiologists do a warm-up. I'm suggesting that all anesthesiologists, if the question is, this patient might need a fiber optic intubation, but I haven't done one in a really long time, so I'm going to cancel the case, or I'm going to choose this other device that I'm not as familiar with and hope that I can get a tube or things like this. I'm saying if you have this in your skill set but you haven't used it in a while and you're afraid to use it because you're rusty with it, by all means, do a warm-up. Get your confidence level up. Get your hands used to the procedure. The skill is there. It's just a question of bringing it fresh into your armamentum so you can actually use it in the cases where it's indicated. The worst, sorry?
Like a dress rehearsal, basically.
Yeah, like a dress rehearsal. I mean, the worst thing in my mind would be if you think it's indicated and you don't perform it because you just haven't done it in a while. That is, in my mind, that could be trading patient safety for practitioner comfort.
Okay. Thank you very much.
Thank you.